Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Azathioprine. It is a synthetic prodrug of 6-mercaptopurine. Why one will produce a prodrug? To increase its T-half. 6-mercaptopurine has just T-half of 2 hours. But our azathioprine, a prodrug which is having nearly 5 hours of T-half. Coming to formulations, it is available in tablets 50 mg, 75 mg and 100 mg. Injections 100 mg per vial. It is absorbed well, that is more than 80% of the drug will be absorbed from the gut. Food may decrease its absorption. It won't cross blood-brain barrier, but it can easily crosses the placenta. And even found in breast milk. Within 2 hours, it reaches its peak plasma concentration. Bioavailability is 60%. Very less plasma protein bound, that is 30%. It is metabolized in liver and also in RBCs. Azathioprine rapidly converts into 6-mercaptopurine because it doesn't need any enzymes to get converted to 6-mercaptopurine. Non-enzymatic rapid conversion will happen immediately within liver and within RBCs. And now this 6-mercaptopurine will undergo two pathways. One is anabolic pathway, which is mediated by HGPRT enzyme, that is hypoxanthine guanine phosphoribosyl transferase. Another one is catabolic or degradative pathway, mediated by 2-xanthine oxidase and TPMT, thiopurine methyl transferase. These two enzymes will lead to inactive metabolites that are excreted via urine. There are two pathways in catabolic side. There is only one pathway in anabolic side. If either of one pathway in two catabolic pathways is blocked, if we give allopurinol, this xanthine oxidase will get inhibited, so that majority of the azathioprine will be diverted towards anabolic pathway and leads to formation of active metabolite, that is 6-thioguanine monophosphate. This thioguanine is very toxic and can lead to catastrophic myelosuppression. If any one of these catabolic pathway is defective, there is increased chances of catastrophic myelosuppression. So that before starting azathioprine, we should always check whether the patient is on any xanthine oxidase inhibitors like allopurinol and TPMT levels in RBCs. If TPMT levels are good, this drug will get eliminated from our body without causing increased risk of catastrophic myelosuppression. I am repeating these words multiple times, that is catastrophic myelosuppression. We have to be very careful about these two enzymes, TPMT and xanthine oxidase. They have to work properly to save the patient from catastrophic myelosuppression. Now this toxic thioguanine is a purine analog, not a true purine. Guanine is a true purine. Thioguanine is a purine analog. It will resemble endogenous purine and gets easily incorporated into DNA, RNA and inhibits purine metabolism. That is, it inhibits purine synthesis. If no purines are there, no cell division will occur. So it mainly affects rapidly dividing cells in the bone marrow. That's why it can cause myelosuppression. Now, what is its main mechanism of action which we want? That is immunosuppression. What are the actively dividing cells in bone marrow? T cells and B cells. Mainly, we want to suppress antibody production by B cells to treat immunobullous diseases like pemphigus vulgaris, bullous pemphigoid and cicatricial pemphigoid. What are the US FDA approved uses of azathioprine? There is nothing related to skin. One is organ transplantation, another one is rheumatoid arthritis. To prevent from rejection of transplanted organ, and for rheumatoid arthritis only FDA has approved Azathioprine. But we are using that immunosuppression property in many skin related diseases like autoimmune diseases, SLE, DLE, dermato and polymyositis. Neutrophilic dermatosis like Behçet's pyoderma gangrenosum, vasculitis, leukocytoclastic granulomatosis with polyangiitis, dermatitis atopic and contact dermatitis, papulosquamous diseases like psoriasis and lichen planus, photodermatosis like PMLE, chronic actinic dermatitis, others sarcoidosis, chronic graft versus host disease. These are all the off-label uses. Coming to contraindications, absolute contraindication is pregnancy. As it is a category D drug, you should never give to pregnants, particularly in first trimester where most of the organs will be forming. Relative contraindication is lactation. It is found in very little amounts in breast milk. If we wait for 4 hours after taking azathioprine, later after 4 hours we can allow for breastfeeding. So it became a relative contraindication, but pregnancy is absolute contraindication. For any drug, hypersensitivity is absolute contraindication. Active infections. When we are giving a immunosuppressant, active infection becomes an absolute contraindication. Along with alkylating agents, it increases the risk of cancers. If we give along with allopurinol, it increases the risk of toxicity, that is catastrophic myelosuppression. So what we can do? We have to reduce the dose of azathioprine by 75%. Just 25% of the drug we can give when we are giving along with allopurinol, because majority of the drug will be diverted to anabolic pathway, that is HGPRT mediated, and leads to toxic active metabolite, so that is 6-thioguanine. I have told this already while dealing here. Every drug will be diverted to form 6-thioguanine if any of this catabolic pathway is obstructed. Coming to adverse effects of azathioprine. For each and every heading I am writing the drug name also, because we should be very careful while studying. Many drugs will be overlapping side effects, so we should remember what is the particular side effect each drug is having from deriving by its name itself, because in exam under stress we can forget which drug is having which adverse effect. In question paper only this drug name will be given, so we should read in such a way that we can derive as many points as we can from the drug name itself. While you are reading by yourself, you can get some mnemonics, you will get some ideas. It should be from this name itself, because you can see the drug name in question paper. You should derive some points by yourself. Now I have highlighted 3 letters, T, H and I. T for teratogenic drug, H for hematological side effect, which is rare bone marrow suppression. Another H is for hepatic, that is also rare but life-threatening elevation of transaminases can happen. Another H is for hypersensitivity, urticaria, angioedema, erythema multiforme. Another H is for hair, anagen effluvium. Now I is for infections. While we are making the patient immunosuppressed, he will be more prone to HSV and HPV infections. So all the side effects we have completed by 3 letters, T, H, I from azathioprine itself. We should be very careful while studying each and every drug. Most common side effects are GI side effects like nausea, vomiting, diarrhea. Teratogenicity, because it can cross placenta easily. It is a category D drug. Carcinogenicity, most common cancers are squamous cell carcinoma, non-Hodgkin's B cell lymphoma. The reasons for carcinogenicity are we are suppressing immunity, so there is no one to act against Epstein-Barr virus. It can cause cancer. Coming to investigations and monitoring of azathioprine. we should always ask for the history of usage of allopurinol. We know it is a xanthine oxidase inhibitor. Alkylating agents. If we give along with alkylating agents, it will increase the risk of cancer. ACE inhibitors will increase the risk of leukopenia. Baseline TPMT levels in RBCs. It's a must and should before starting azathioprine. FDA recommends to do genotyping for TMT genes, that is sequencing of alleles. If wild alleles are found, it will be having good activity. If mutant alleles are found, it will be having very less activity. By this way, we can check how TPMT activity is there, or else we can check TPMT enzyme levels in RBC, and we have to categorize into 3. One is high TPMT levels or high TPMT activity, medium and low. Remember, only medium, that is 6.3 to 15 units per ml. For this, we will give 1 mg per kg. Remember, 6.3 to 15. If it is less than 6.3, don't even start the drug. If it is more than 15, you can give so much of dosage, that is 2 to 2.5 mg per kg per day. If it is medium, in between 6.3 to 15, just 1 mg per kg per day. What is the recommended dose? From 1 to 3 mg per kg. If TPMT levels are very high, activity is very good, you can give high dosages of drugs, that is 2 to 2.5 mg also. CBC with differential count, because it can lead to pancytopenia, that is it can reduce RBCs, it can reduce WBCs, it can reduce platelets. If platelets are reduced, patient will be easily prone to bruising, bleeding. If WBCs are reduced, patients will be easily prone to infections. If RBCs are reduced, patient will be easily prone to anemia. So that you should always tell the patient, whenever you get repeated infections, easy bruising, or if you feel anemic, you have to come and check TPMT levels again. Usually, if we check only once, that is before starting the drug, TPMT levels is okay. For high risk patients like this, who are more prone to repeated infections, we have to check how TPMT is functioning. If TPMT is functioning good, you have to continue azathioprine. Otherwise, you have to stop the drug if TPMT levels are not that much good. First 2 months are very important. You have to do bi-weekly follow-up for 2 months. Then you can do 3 months once. Before starting the drug, you have to check whether the lady is pregnant or not. If the lady is in reproductive age group. Then tuberculin skin test. In one of my video, I have told you lung rule, not thumb rule. Whenever we are starting immunosuppressant, we have to check for latent TB. Either it may be tuberculin skin test, IGRA, X-ray. Coming to drug interactions, azathioprine reduces anticoagulant effect of warfarin and serum levels of cyclosporin. Here, azathioprine is acting as a culprit in reducing warfarin and cyclosporin. Now we will see some other culprits who acts on azathioprine. Xanthine oxidase inhibitors, allopurinol, febuxostat, xanthine oxidase XO, febuxostat XO. It is also reducing xanthine oxidase levels. TPMT inhibitors, sulfasalazine. Methotrexate also increases 6-mercaptopurine. All these three are leading to anabolic pathway, HGPRT mediated, and formation of toxic active metabolite 6-thioguanine, which leads to catastrophic myelosuppression. Here you can see all these three are increasing the risk of catastrophic myelosuppression. Next, ACE inhibitors will increase the risk of leukopenia, alkylating agent, malignancies. I will tell one example of alkylating agent, that is cyclophosphamide. We will deal in our next class with cyclophosphamide. When I am reading about ACE inhibitors, I have forgot to tell you while dealing with oral antioxidants. This mnemonic ACE blockers. Vitamins which are having antioxidant property are ACE blockers. A for vitamin A, C for vitamin C, E for vitamin E, and blockers. ACE blockers. B for vitamin B3. All these are antioxidants which this mnemonic I forgot to tell in my sunscreen class. Now I have covered. Remember my channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.